They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Hi, thank you so much for joining us for this episode of Being Well. I'm your host, Keanne Armstrong. Today we are going to be talking about breast disease and all the details involved that you may be asking yourself questions about, and today we're going to try to answer those for you. And joining me today is Dr. Ruben Boyajian. He is a general surgeon with a subspecialty in breast disease, and he is the Director of Women's Health with HSHS St. Anthony's in Effingham. Thank you so much for joining me today.
Thank you, Keanne.
It's a pleasure having you on the show.
Thank you.
This is a very important topic that a lot of people suffer with these days, and we're here to answer a lot of questions for our viewers. So I want you to introduce yourself, some things that you do in your practice, and then we'll get into the details of breast disease.
Thank you. Pleasure to be here. I'm a general surgeon, and as such, we do a number of procedures, but my main interest has always been breast disease, with particular attention to breast cancer. And we devoted a lot of time on training, and there is a lot to learn and to investigate about breast disease. That is a number one leading cancer in women that don't smoke. The second one will be lung cancer if you're a smoker. So,
very important topic to discuss then, if it rates that high on the list of problems that women suffer with.
That's right.
Yeah. So breast disease, is it always cancer? Are there various types of breast disease? Go into a few of the different, I guess, titles or names of different things that you work with.
Right. Thank you. That's a great question, Keanne, because the majority of issues affecting the breast are not cancers. But of course, cancer gets the attention, you know. Why wouldn't it?
Yeah, because it's scary, and that's the first thing.
That is the threat.
Yeah, and people think, you know, maybe this is what I have, when not always is that the case from what you're telling me. Yeah.
Correct. And then you have to also look at the age group, the persons affected. Just to give an example, the most common tumor is actually a fibroadenoma, and that is a tumor that is totally benign and affects the younger women. Even teenagers, you know, 20s, 30s, and it could stay with you undetected. Typically, you will feel a lump on the breast, and that triggers the alarm invariably, you know, no matter how old you are or how young. So the concern is always, my God, I have a cancer.
Right.
But fibroadenoma is known to be benign. It's frequent. Sometimes you get more than one. When they are close to the breast surface, close to the skin, then it becomes detectable by palpation, by feeling. And that is usually the way it's discovered. Most fibroadenomas are diagnosed with a simple needle biopsy, a core biopsy. Most of them don't require even surgery, although that is an option. But that is the most frequent as far as tumors of the breast go.
Okay.
The second issue with the breast is also something called fat necrosis. And that can be due to trauma to the breast, major or minor, and a portion of fatty tissue will melt down and then heal with a capsule, and it feels and it looks like a tumor. Even on mammography, an ultrasound could look exactly like a breast cancer would. And then on biopsy, you confirm that it's not. Great news.
Yeah.
And it's called fat necrosis, and that usually heals by itself.
Okay.
Other problems with the breast involve like nipple discharge and inflammation, and depending on the let's say if the woman is lactating or nursing a baby, you can get mastitis, and those are all benign conditions that are treatable with medications or with minor surgical procedures.
Okay. So a variety of different things to be concerned with, but not always to be concerned that it's cancer.
Correct.
Yeah. So
I'm sorry, another frequent call in benign disease that affects men is an enlargement in the breast, particularly in adolescents, and it's called gynecomastia. It's always a concern, trying to figure out is it normal, abnormal, or what. So that's another category of interesting breast changes that represent no threat to the lifespan, longevity of the person, and don't require any surgery as well.
yeah, those are good things to know because, like you did mention, you feel something, you notice something a little different or something that's not quite what was happening before.
Correct.
And then the first thing you do is think, oh my goodness, I do have cancer. But in order to diagnose that it is or is not, what are some tests or screenings that you do to let people know exactly what's going on inside their body?
Well, Kian, you had the ability to ask the great questions there because that comes next. The national effort right now is to make the biopsies as minimal as possible. We don't want to collect scars in the breast, and that's very critical. And thankfully, we have techniques like core biopsies done under ultrasound guidance usually, and that takes representative cores that look like portions of a spaghetti, and those are sufficient to produce a very accurate diagnosis without making an incision in the breast and creating a scar.
All right.
So the majority, I would say close to 100% of breast issues can be diagnosed by minimal intervention in that manner.
Okay, so when you are talking about this, do you use a needle or is it just, explain the process.
The
so
core
people,
biopsy is a bit different than just suctioning fluid from a tiny needle. It's a bit larger, but it's done under local anesthesia, and it actually cores out. It's a spring-loaded device, and it cores out tissue and is recovered within the device and is placed in a special solution and analyzed accordingly.
Okay, so it doesn't sound as painful maybe. People are afraid of needles.
Actually, it's really painless.
It is
painless.
painless.
Yes.
Oh, that's good to know
Yeah.
because you hear a lot of times people are like, oh my goodness, I hate needles, I don't want to get this done.
Yeah,
And
it's done with a local anesthetic, which also inject the anesthetic with a very tiny device under the ultrasound guidance along the trajectory of what the device, is going to be predicted to go.
Okay, so is this something that's new? Has it been around for a while?
It's been around, but now it's been adopted as the standard of care, meaning that that's the way the biopsy should be done.
Okay. You said it was critical to make sure that there wasn't scarring due to biopsies, and why is that so critical?
Well, breast, I think that's important in any area of the body, but breasts are such a, how can I say this? It's an important part and component of our perception or our bodies, and is emotionally charged as well. And there is pressure, there's pressure in society to maintain a good appearance. Even most of the commercials about clothing and et cetera, always show a scar-free breast profile,
Right.
or at least on the upper chest.
Yeah.
And but that's true for everything. As you know, surgery in any areas, even abdominal and other procedures, is being minimized either by laparoscopic techniques, and avoidance of major incisions.
Yeah, I understand what you're saying there. Because it is important, how a person not only views themselves, but, all of these different things that you feel like you have to look good, but you want to feel good at the same time. So there's a lot of pressure and anxiety that would come into play.
Correct.
Yeah. So let's talk about screenings and mammographies. How much is too much? How much is too little? What's the going rate at when you should start and how often?
Wow. That is a subject that has, been surrounded by some controversy. Mm-hmm. There are several guidelines, and I don't like that too well. When you have too many guidelines, which one do you pick?
Right, confusing.
So you want to see one guideline, and that's it. And I explain that in a minute. Typically, you want to match the imaging or the search for a problem following the incidence of the disease. Breast cancer is going to start increasing the frequency after age 40. Mm-hmm. So there's no sense or screening, when you're a teenager or in your 20s or 30s. So therefore, traditionally, a baseline mammogram is performed at age 40 and then continues yearly for the rest of your life.
Okay.
This concept has been challenged. The U.S. task force decided, based on some studies, that maybe this is too much, and the screening should start after age 45 or even 50, and then continue like every 2 years or so. This was also, it's been contentious. Our Society of Breast Surgeons and the American College of Radiology maintains the position that should be done every year after age 40.
Okay.
The American Cancer Society kind of shifted and went with the U.S. task force and began recommending the screening at age 45 and continuing every year until age 54 or 55, and then every 2 years thereafter.
Okay.
The problem here is that some of the studies were based on reports, one of them from Canada, based on technology from the 80s and showing a higher degree of inaccuracy in the reporting. There was this concern that such a technology could lead to unnecessary biopsies, and therefore, it was modified. But the current mammography, 3D, tomography, and digital is so accurate that I think that from my own experience, we have a large volume of breast cancer cases to care for. And I see patients like from 1 year to the next. On the prior mammogram, it was totally clear. And then on the next one, a year later, there is like a full moon in a clear sky. And knowing that this happens with some frequency, then it makes you feel like, I don't want to miss the window of finding the cancer earlier, sooner than later.
Because it is important to find the early detection.
Correct.
And because you want to catch it early so it doesn't progress, is that right?
Correct.
Yeah, very important for that. So is it only women that get these screenings, or you mentioned breast cancer in men? Do men go at age 40, or what's the...
For men, we are different creatures, I guess, but we do have nipples, if I can say that. But the frequency of breast cancer in men is much lower.
All right.
It's like for every 100 women with breast cancer, only 1 man will have it. And therefore, screening is not recommended.
Okay.
Also, the examination in a man is easier because any remnant of breast gland is right under the nipple area, so it's easier to perceive there is a lump developing or not.
Okay. Well, speaking of that and catching it early, we've talked about the variety of breast diseases, and you mentioned that not all of them are cancer. So are there a variety of breast cancers or is there only one?
No, there is a good number of different types of breast cancers. The majority are called invasive ductal carcinoma. Those are the majority, but then there are other types such as mucinous cancers, tubular, lobular. So there's a number of situations that it could make it very complex, and parts of the techniques of identification include trying to separate, these different types of cancers. Some of them are not as aggressive. There is also the issue of sensitivity. Is the cancer hormone sensitive, like estrogen, progesterone? And there is another protein called HER2/neu, it's called. And then we have the triple negative cancers that are hormone receptor negative, and those are usually more aggressive. So there's a lot that goes on behind the scenes identifying the type of cancer. That tends to make the patient, as a patient, after you do the biopsy, is like, what's taking so long? You can't have the result the next day because all these tests have to be performed in a very accurate manner.
Well, I'm sure it's nerve-wracking for the
It is,
patients.
right.
You can't see what's going on inside of your body, and when you're going in for the test, you're anxious, you're scared, and then you're wanting that result, as soon as you can get it, so you know what's going on.
That's right.
and what's
Yeah.
going to be the next step. So how do you handle situations like that with your patients and balancing, the treatment for what is taking place, if it is something that is cancerous, versus helping them with the anxiety and the stress that comes along with it?
We'll keep them informed, full transparency, and the results of the biopsy I communicate via personal call. I usually do that myself. If there is any delay, I'll let him know what's going on. This is going to take a bit longer. And then we make an office visit, a consultation with oncologists. It's a team approach.
Yeah.
It's called multidisciplinary. And this is another newer way of approaching the disease and do the treatment planning that will be concordant with national standards that are known to produce better results. So
Sounds like there's open communication, and keeping the patient informed is something
Correct.
that really is very helpful.
And we produce copies of the report so they know exactly what our principle is that what I know about this patient's cancer, they will know exactly the same information they will have as well.
Yeah.
So there will be no hidden areas,
Right.
in other words.
That lessens the anxiety.
Right.
Good to know. What about genetics and heredity? How does that filter in? Because there's some things that we can do to try and keep ourselves healthy, but where does this play? Is there people who are just going to have to deal with this because it's been a part of their family? Tell me about that.
You're pressing all the hot buttons here.
That's my job. We got to get this information out to our viewers, and these are important topics
Right.
and things that we hear about.
Well, the genetics, we all come from somewhere, somehow.
Yeah.
So the individual life is created based on the genes that are transmitted, and God knows the forces that have occurred before us, and the gene codes and stuff. There is also a national and worldwide anxiety about the genetic issue. The truth is that percentage-wise, only 5 to 10% of breast cancers are hereditary.
Oh, okay.
So the majority are more frequent than hereditary.
All right.
So, but it does get the attention. You always think, well, is it in the family or not? I try to explain to the public and patients that it's best not to be too obsessed with it, but to do your homework, do your family tree, find out who has what, and figure, if anybody had breast cancer, at what age. That's very important.
Yeah.
The cancers that are genetically transmitted, like the BRCA gene, usually could affect the younger women. It's different if you have an aunt at age 95 that had the cancer versus somebody at age 40. So, those are more likely to be to have some genetic influence and penetrance, we call it.
Okay. We've talked a number of varieties of the diseases, the breast cancers, and if somebody does have to have surgical options and then they have to go into breast reconstruction, explain a little bit about breast reconstruction and what that entails.
That is a serious issue.
Okay.
The breast reconstruction, no matter what technique is used, is not a drive-through, and you're done and you walk away with a new breast. It's a process. One of our last meetings with the Society of Breast Surgeons, there was a lot of emphasis in trying to make sure that we transmit that to the patients, to understand that the reconstruction is not a single event, it's a process.
It takes time.
Example, I might need a tissue expander. It needs a gradual inflation to allow for a capsule to form, and then the expander is removed, and then the implant is placed. So then it's a process.
Okay.
And there is some variance depending on the type of cancer, the location, the person's body shape and weight, and size of the breast. There's a lot of factors that will influence. And also the most important one is what the patient would like. Then as soon as we figure that out, then we have to see if this is safe and possible. The patient may like that as a desire, sounds good, but it may not qualify for such.
Okay. We've got a couple of minutes left,
right.
And you seem very personable. You sound like you really want to make sure that your patients are comfortable, they're in the know, they know exactly what's going on. What's the most difficult scenario that you've dealt with diagnosing a newly breast cancer patient?
Kian, the most difficult aspect of this is the person's desire to have a double mastectomy. This has been, something that hits the media. Some of the personalities that out there appear on TV, and explain that they have a successful, story about removing the two breasts. I usually ask the patient, what do you think your risk of a breast cancer on the other breast would be? Invariably, they tell me 100%, 60%, 80%. When I explain to them based on realistic charts that is only 5% or less in a 10-year span, they get surprised. They said, and then we explain that it may not be necessary to do a double mastectomy,
which is
based on the fear
news.
And the emotional component of the knowledge that you just had a cancer discovered.
Okay. In closing, what would you like our viewers to gain from our show today? Is there any advice, any information you'd like to wrap up the show with?
I sure would, and thank you for the opportunity. I would say keep cool, filter all the information out there, media, magazines, take it with a grain of salt. Try to learn. We are willing to teach. Don't panic. This is a very measurable and curable disease, unlike other internal cancers that you can't see or detect as easily. So keep your chin up. And I also tell them, drive carefully, don't text and drive.
There you go, that's good. We got to stay on top of our screenings, take care of ourselves, and take care of others out there as well.
Right.
All right, well, thank you so much.
Thank you, Kian.
Very informative.
Great. I appreciate the opportunity.
I appreciate you coming in as well.
Thank you.
And we would like to thank you for tuning in today for this episode. We hope that it has been informative and educational, and we'll see you next week.
At HSHS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.